The bougie double lumen tube length relationship. I have chosen two very familiar items, the Sheridan Sherry Bronc double lumen tube and the SunMed intubating bougie, rather arbitrarily, for no other reason than they are both in widespread use and you are likely to encounter them in daily practice in North America. So now, let's evaluate the relative length of this 70 cm 15 French SunMed bougie compared to the length of the commonly used Sheridan Sherry Bronc 37 French gauge left-sided double lumen tube. I have chosen this double lumen tube because it is a highly representative example of a 46 cm long adult double lumen tube. At this point, we still have to answer a rather fundamental question for this procedure to succeed. Will the diameter of the bronchial lumen be adequate to allow the passage of this 15 French SunMed bougie? Well, you may think that this should be entirely predictable before we even remove these devices from their packaging. Unfortunately, this is very definitely not so, and this challenging and problematic topic is dealt with in an accompanying video on non-standardization of double lumen tube dimensions. Anyway, let's move on. So first, we take our bougie and we obliterate the coude tip just enough to make it easier to pass this wide bougie through the narrow lumens of the double lumen tube. We always use the bronchial lumen when we anticipate the need for a bougie. We lubricate the bronchial lumen very generously with silicone spray. We insert the bougie into the lumen, and now the tip of the bougie is at the very end of the bronchial lumen. For double lumen tube intubation over a bougie, we proceed exactly as we would for single lumen tube intubation. I place my fingertips at either 21 or 23 centimeters, and as I insert the bougie, this means I naturally have to stop at the incisor teeth and can never insert more than 21 to 23 centimeters inadvertently. This portion of the bougie is the internal component of the bougie, and here we have this much which constitutes the external portion of the bougie. So here we have the bougie double lumen tube length relationship. And the next fundamental question we must answer is this: is this external portion of the bougie an adequate length with which to work? To be more precise, will the external portion of the bougie accommodate the entire length of this double lumen tube with excess length of 2 or 3 centimeters available, which will allow us to have an upper or lower control zone? And this, a control zone, is essential to prevent dangerous accidental advancement of the bougie. Remember, we need to insert the bougie a minimum distance into the trachea, at least to the midtracheal point, to avoid the flip-out phenomena. So we need to have a minimum length of the external portion of the bougie on which to mount the double lumen tube. And of course, thinking ahead, at the end of the surgical procedure, if we need to change from a double lumen tube to a single lumen tube for weaning off the ventilator, we will need exactly the same length of external portion of the bougie over which to extubate. But we still need at least 2 or 3 extra centimeters to act as either an upper or a lower control zone. So we have to determine exactly how much bougie needs to be in the patient at this point to safely deliver the bronchial tube's tip to the midtracheal point. With the tip of the bronchial lumen level with the patient's upper incisor, we need a good distance of bougie, approximately 21 to 23 centimeters of bougie beyond the upper incisor, to have the tip of the bougie in the midtracheal point. Exactly as we do for single lumen tube, that is conventional tube, intubation over a bougie. And this should be adequate to prevent the flip-out phenomena and subsequent failure of the double lumen tube intubation. So at this point, we can consider the very simple arithmetic to predict the adequacy of the length of the external portion of the bougie. The external portion is the total length of the bougie minus the minimal acceptable internal portion. And for this specific double lumen tube to bougie length combination to be viable, the external component of the bougie must be at least 2 to 3 centimeters longer than the total length of the chosen double lumen tube. In summary, with an internal bougie portion of 21 to 23 centimeters. Will the remaining external component of the bougie safely accommodate the entire length of the chosen double lumen tube with enough additional length to provide a small upper or lower control zone? Thank you for listening. Why do we have such difficulties intubating with a double lumen tube? Welcome. This little video makes it obvious why we always mount the double lumen tube on its bougie using the bronchial lumen. Consider airway scenario number 6. A thoracic surgery patient requires double lumen tube for lung isolation, and this is requested by the thoracic surgeon. After induction of general anesthesia and the onset of full muscle relaxation, a laryngoscopy is performed. The larynx appears anterior. Several attempts at double lumen tube intubation are tried and fail, and a decision to intubate over a bougie is made. Now, this patient is a very tall man, approximately 6 feet 4 inches, and a 41 French gauge double lumen tube has been selected. The 70 centimeter Sunmed bougie is advanced to the presumed mid-tracheal point, placing the 25 centimeter calibration at the upper incisor teeth because the patient is so very tall. And this point on the bougie will be used as the lower control zone, and the double lumen tube is mounted on the bougie. Unfortunately, as the double lumen tube is advanced down the bougie, when the bronchial lumen exit orifice arrives at the lower control zone, you realize that this bougie is just not going to be long enough. The tip of the bougie fails to appear at the connector at the proximal entrance orifice of the double lumen tube. You simply cannot understand how this situation could arise. Why would any manufacturer make a bougie that is too short for a double lumen tube? You call your anesthesia technician and ask them if they have a longer bougie, and they bring you the 100 centimeter extra long intubating bougie for double lumen tubes, but unfortunately this device is quite floppy, and because double lumen tubes are so stiff, it can occasionally lead to the flip-out phenomena. The patient's arterial oxygen saturation is starting to decrease, and the surgeon makes the decision that he can manage the surgery on a single lumen tube. Now, This plan is far from ideal, but he feels it is better than exposing the patient to what could be serious episodes of hypoxemia. So how could this situation have been avoided? In fact, this situation could easily have been avoided before induction of anesthesia by taking your equipment, lubricating the bronchial lumen of the double lumen tube, and passing the 70 centimeter intubating bougie through the lumen to ensure adequate length. That is, the internal portion should be 25 centimeters long, and the external portion of the bougie 46 to 48 centimeters long, depending on the double lumen tube length. And of course, you will need at least 2 centimeters for a control zone, because you only need to have one control zone at a time. Doing this would have revealed the bougie to be too short, and alternative strategies to avoid this situation could have been employed. Now, we will talk about these alternative strategies in a later video. At this point, let's proceed to airway scenario number 7. It is very similar to the preceding scenario, but the patient is a normal size. We're not dealing with a very tall man in this scenario. A bougie is inserted to 23 centimeters at the upper incisor teeth, and when the double lumen tube is mounted on the bougie and advanced toward the patient's mouth, the proximal tip of the bougie hits an obstruction inside the bronchial lumen near its entry orifice. See these images and study the short movie. Can you hear the bumping sound? The proximal end of the intubating bougie is in fact consistently hitting a prominent ridge at the end of the double lumen tube connector. This is another problematic design flaw of double lumen tubes, and this could have been discovered preoperatively by ensuring the ability of the double lumen tube to pass over the entire length of the bougie prior to the beginning of the procedure. I cannot emphasize enough, when using bougies with double lumen tubes, you must ensure that the chosen bougie is long enough for the chosen double lumen tube with at least 23 centimeters to spare to act as the internal portion of the bougie. Now, the fix for this situation is much more difficult. Sometimes, after 5 or 6 advancements, the tip of the bougie will pass, reason unknown, but sometimes it may be necessary to twist or rotate the double lumen tube relative to the bougie, but you must ensure not to advance or withdraw the bougie unintentionally. If this problem persists, you may have no choice but to consider a double lumen tube provided by a different manufacturer if it's available to you. If not, once again, the surgeon may have to rely on a single lumen tube with a bronchial blocker. Now, let's get down to business. The first characteristic making double lumen tube intubation difficult is that it is a long, bulky device which has only a small degree of freedom in the short, narrow airway. Another problematic area is a unique feature of the double lumen tube, and that is, it has a vertical diaphragm separating bronchial and tracheal lumens as shown here. And this confers the entire device with rigidity, while ideally we would prefer it to be more soft and flexible. We just do not have an intubating bougie stiff enough to consistently impose its trajectory on the very stiff double lumen tube. Another very important area generating unnecessary difficulty in the use of double lumen tubes resides in the non-interchangeability of tubes from different manufacturers. Two very popular double lumen tubes are the Ruche series and the Sheridan Sherry Bronx series of double lumen tubes. Now, both the tracheal and bronchial lumens of the Sheridan double lumen tubes are adequate to accept a 15 French gauge Sunmed bougie, which is a wonderful feature of these double lumen tubes. However, all the double lumen tubes in this series are exactly the same length, and that length is actually so long, it happens to make it difficult to intubate over 70 centimeter bougie. The Ruche series of double lumen tubes are all different lengths, and so the 3 smaller tubes are easy to intubate over a bougie, but unfortunately the longer size 41 French gauge is so long it can be challenging to intubate with it. There is no problem, however, passing a bougie through the tracheal and bronchial lumens of the 41 French gauge. It is consistently impossible, however, to pass a bougie through the bronchial lumen of the two smaller sizes, the 35 and the 37 French gauge, and for the remaining model, the 39 French gauge, believe it or not, it's hit or miss whether a bougie will actually pass down its bronchial lumen. It seems to depend on the physical dimensions of that particular batch of tubes from the manufacturer. See the accompanying images on how the lip at the end of the double lumen tube, that is, at the exit orifice of the bronchial lumen, sometimes presents an obstruction, and this seems like a ludicrous situation. More on this in the section on difficult double lumen tube intubation in another video.